Okay, pages 1550 to 1559, cystitis. The components of the urinary system are the ureters, bladder, and urethra. Their function are to store the urine made by the kidney and eliminate it from the body. These actions do not contribute to the homeostatic purposes of the human need for urinary elimination. However, when problems in the urinary system interfere with the mechanics of moving urine out of the body, the human need for urinary elimination is not met and homeostasis of fluids, electrolytes, nitrogenous wastes, and blood pressure is disrupted. Urinary problems affect the storage or elimination of urine. Both acute and chronic urinary problems are common and costly. More than 20 million people in the United States are treated annually for urinary tract infections, cystitis, kidney and ureter stones, or urinary incontinence. Although life-threatening complications are rare with urinary problems, patients may have significant functional, physical, and psychosocial changes that reduce quality of life. Nursing interventions are directed toward prevention, detection, and management of urologic disorders. Infectious disorders. Infections of the urinary tract and kidneys are common, especially among women. Manifestations of urinary tract infection, or UTI, account for more than 7 million healthcare visits and 1 million hospital admissions annually in the United States. UTIs are the most common hospital-acquired infection. Total direct and indirect costs for adult urinary tract infections are estimated at $1.6 billion each year. Urinary tract infections are described by their location in the tract. Acute infections in the lower urinary tract include urethritis in the urethra, cystitis in the bladder, and prostatitis in the prostate gland. Acute pyelonephritis in an upper urinary tract or kidney infection, or is an upper urinary tract kidney infection. The site of infection is important to know because site, along with the specific type of bacteria present, determines treatment. Several risk factors are associated with occurrence of UTIs. Cystitis Pathophysiology. Cystitis is an inflammation of the bladder. It can be caused by irritation or, more commonly, by infection from bacteria, viruses, fungi, or parasites. Infectious cystitis is the most common of the UTIs. Non-infectious cystitis is caused by irritation from chemicals or radiation. Interstitial cystitis is an inflammatory disease that has no known cause. Infectious agents, most commonly bacteria, move up the urinary tract from the external urethra to the bladder. Less common spread of infection through the blood and lymph fluid can occur. Once bacteria enter the urinary tract, several factors influence the outcome. Table 69.2. The presence of bacteria in the urine is bacteria and can occur with any urologic infection. When bacteria is without symptoms of infection, it is called colonization. Colonization, asymptomatic bacteriuria, is more common in older adults. This problem does not appear to progress to acute infection or renal insufficiency unless the patient has other pathologic problems and then requires treatment. Table 69.1. Factors contributing to urinary tract infection. Obstruction. Incomplete bladder emptying creates a continuous pool of urine in which bacteria can grow. It prevents flushing out of bacteria and allows bacteria to ascend more easily to higher structures. Bacteria have a greater chance of multiplying the longer they remain in residual urine. Overdistension of the bladder damages the mucosa and allows bacteria to invade the bladder wall. Stones. Large stones can obstruct urine flow or calculi. The rough surface of a stone irritates mucosal surfaces and creates a spot where bacteria can establish and grow. Bacteria can live within stones and cause reinfection. Vesicouretal reflux. Bacteria-laden urine is forced backward from the bladder up into the ureters and kidneys, where pyelonephritis can develop. Reflux of sterile urine can cause kidney scarring, which may promote kidney dysfunction. Diabetes mellitus. Excess glucose in urine provides a rich medium for bacterial growth. Peripheral neuropathy affects bladder innervation and leads to a flaccid bladder and incomplete bladder emptying. Characteristics of urine. Alkalotic urine promotes bacterial growth. Concentrated urine promotes bacterial growth. Gender. Women are susceptible to periurethral colonization with coliform bacteria. Use of diaphragms, frequency of intercourse, and a new partner within the past year are associated with UTI in women. Bladder displacement during pregnancy predisposes women to cystitis and the development of pyelonephritis. A diaphragm or pessary that is too large can obstruct urine flow or traumatize the urethra. Urinary stasis, now on to age. Urinary stasis may be caused by incomplete bladder emptying as a result of an enlarged prostate in men and cystocele and prolapse in women. Neuromuscular conditions that cause incomplete bladder emptying, such as Parkinson's disease and strokes, affect older adults more frequently. The use of anticholinergic drugs in older adults contributes to delayed bladder emptying. Fecal incontinence contributes to poor perineal hygiene. Hypoestrogenism in older women adversely affects the cells of the vagina and urethra, making them more susceptible to infections. Sexual activity. Irritation of the perineum and urethra during intercourse can promote migration of bacteria from the perineal area to the urinary tract in some women. Spermicides can alter vaginal pH, increasing potential numbers of pathogens. Inadequate vaginal lubrication may exacerbate potential urethral irritation. Bacteria may be introduced into the man's urethra during anal intercourse or during vaginal intercourse with a woman who has bacterial vaginitis. Recent use of antibiotics. Antibiotics change normal protective flora, providing opportunity for pathogenic bacterial overgrowth and colonization. Important factors influencing the outcome of urinary tract infections. Facilitating aspects. Anatomy. Females, short length of the urethra and its proximity to the vagina and rectum facilitates colonization of coliform bacteria. Males, long length of the urethra and this would be protective aspects. Males, long length of urethra and its distance from the rectum provides protection from colonization with coliform bacteria. Anatomy, facilitating aspects for male. With age, the prostate enlarges and may obstruct the normal flow of urine, producing stasis. Physiology, facilitating aspects. Females, pregnancy predisposes a woman to ureteral reflux and subsequent pyelonephritis. With age, the decline in estrogen facilitates colonization of E. coli. In addition, vaginal atrophy can alter urethral competency. With males, with age, prostatic secretions lose their antibacterial characteristics and predispose to bacterial proliferation in urine. Protective aspects with physiology. Females, well estrogenized mucosa in the urethra and trigone may inhibit bacterial colonization and enhance urogenital blood flow. Males, normal prostatic secretions inhibit bacterial growth. Both males and females, mucin is produced by urothelial cells lining the bladder. This helps maintain mucosal integrity and prevent cellular damage. Mucin may also prevent bacteria from adhering to urothelial cells. So trauma, the facilitating aspects of UTIs related to trauma for females would be vaginal penetration with sexual intercourse may traumatize the urethra and bladder base, leading to postcoital or honeymoon cystitis. A vaginal diaphragm that is too large can place pressure on the urethra, causing trauma. Vaginal childbirth can cause permanent damage to the urethra. Males' sexually transmitted diseases may cause urethral strictures that obstruct the flow of the urine and predispose to urinary stasis. Both males and females' urethral instrumentation, e.g. catheterization, may disturb the urothelial surface and predispose to adherence of bacteria that would ordinarily not be pathogenic. Protective for trauma, females' adequate lubrication, either natural or artificial, with intercourse may prevent any trauma. And then infectious agent. Facilitating aspects, some organisms are better able to adhere to host cells and secrete substances that induce inflammation. Protective, a small inoculum or number of microorganisms introduced into the body is more easily flushed away by the flow of urine. Alright, back to the text. Etiology and genetic risk. UTIs, like other infections, are the result of interactions between a pathogen and the host. UTIs, like other infections, are a result of interactions between the pathogen and the host. Usually a high bacterial virulence or ability to invade and infect is needed to overcome normal strong host resilience or resistance. However, a compromised host is more likely to become infected even with bacteria that have low virulence. Genetically, invading bacteria with special adhesions are more likely to cause ascending UTIs that start in the urethra or bladder and move up into the ureter and kidney. Patient-specific genetic factors such as blood type and ability to produce bladder surface biofilms that protect bacteria may influence the risk for UTI. The most common organisms in infectious cystitis are from the intestinal tract. About 90% of UTIs are caused by E. coli. Less common organisms include Staphylococcus saprophyticus, Klebsiella pneumoniae, and organisms from the Proteus and Enterobacter species. In most cases, organisms first grow in the perineal area, then move into the urethra as a result of irritation, trauma, or catheterization of the urinary tract, and finally ascend to the bladder. Catheters are the most common factor placing patients at risk for UTIs in the hospital setting. Within 48 hours of catheter insertion, bacterial colonization begins. About 50% of patients with indwelling catheters become infected within 1 week of catheter insertion. How a catheter-related infection occurs varies between genders. Bacteria from a woman's perineal area are more likely to ascend to the bladder by moving along the outside of the catheter. In men, bacteria tend to gain access to the bladder from inside the lumen of the catheter. Any break in the closed urinary drainage system allows bacteria to move through the urinary tract. Best practices to reduce the risk of catheter contamination and catheter-related UTIs are listed in Chart 69.1. Organisms other than bacteria also can cause cystitis. Fungal infections, such as those caused by Candida, can occur during long-term antibiotic therapy because antibiotics change normal protective flora. Patients who are severely immunosuppressed are receiving corticosteroids or are other immunosuppressive agents, or have diabetes mellitus or acquired immune deficiency syndrome, AIDS, are at high risk for fungal UTIs. Viral and parasitic infections are rare and usually are transferred to the urinary tract from an infection at another body site. For example, Trichomonas, a parasite found in the vagina, can also be found in the urine. Treatment of the vaginal infection, see Chapter 74, also resolves the UTI. Okay. Non-infectious cystitis may result from chemical exposure, such as to drugs, e.g., cyclophosphamide or cytazan or priceitox, and radiation therapy, and from immunologic responses, as with systemic lupus erythematosus or SLE. Chart 69.1, best practice for patient safety and quality care. Minimizing catheter-related infection. Assess patients daily for those who no longer need indwelling catheters. Consider appropriate alternatives to an indwelling catheter. Use a septic routine when handling catheter devices. Manipulation can promote an environment favorable to pathogens. Select a small size catheter, 14 to 18 French, with a 5 milliliter balloon. Use strict sterile technique to insert the catheter in the hospital setting. A break-in technique can introduce pathogens into the urinary tract. Do not inject more than 10 milliliters into the balloon. Maintain a closed system irrigation by ensuring that catheter tubing connections are sealed securely. Disconnections can introduce pathogens into the urinary tract. Avoid routine catheter irrigation. Keep urine collection bags below the level of the bladder at all times. Elevating the collection bag above the bladder causes reflux of pathogens from the bag into the urinary tract. Secure the catheter to the patient's thigh. The patient's thigh for a woman, or lower abdomen for a man. Catheter movement can cause urethral friction and irritation. Perform daily catheter. Does it make any sense? Lower abdomen for a man. That wouldn't be below the thing. That's just weird. Okay. Patient's thigh. Okay. Perform daily catheter care by washing the perineum and proximal portion of the catheter with soap and water and dry gently. Remove pathogens and reduce the pathogenic population. Wash the use of excuse me. Consider the use of coated catheters for patients requiring indwelling catheters for more than 3 to 5 days. This coating reduces bacterial colonization along the catheter. Application of aseptic solutions or antibiotic ointments to the perineal area of catheterized patients has not been demonstrated to have any beneficial effect. Okay. Interstitial cystitis is a rare chronic inflammation of the entire lower urinary tract, bladder, urethra, and adjacent pelvic muscles that is not a result of infection. The condition affects women 10 times more than men, and the diagnosis is difficult to make. Manifestations are similar to those of infectious cystitis, with more intense urgency and bladder pain. Results from urinary analysis and urine culture are negative for infection. That's interstitial cystitis. Although cystitis is not life-threatening, infectious cystitis can lead to life-threatening complications, including pyelonephritis and sepsis. The risk for kidney tissue damage followed by kidney failure as a result of bacteria ascending from the bladder to the kidney is controversial. Severe kidney damage is a rare complication unless the patient also has other predisposing factors such as anatomic abnormalities, pregnancy, obstruction, reflux calculi, or diabetes mellitus. The spread of the infection from the urinary tract to the bloodstream is termed urosepsis. Sepsis from any source is a systemic infection that can lead to overwhelming organ failure, shock, and death. The most common cause of sepsis in the hospitalized patient is a UTI. Sepsis has a high mortality and prolongs hospital stays. Incidence/prevalence. The incidence of UTI is second only to that of upper respiratory infections in primary care. Patients who have frequency and urge to urinate frequently in small amounts, dysuria, pain or burning with urination, and urgency, the feeling that urination will occur immediately, account for more than 5 million health care visits annually. About 50% of these patients will have a confirmed UTI. Considerations for older adults. The prevalence of UTIs varies with age and gender. Women of any age are more commonly affected with UTIs than are men. In men, the incidence of UTI greatly increases after 73 years of age. In women, the prevalence of UTIs increases from 20% among all women to 50% in those older than 80 years. 80 years. Skin and mucous membrane changes from a lack of estrogen appear to account for much of the increased risk in older women. Prostate disease increases risk for UTIs in men. Okay, we got that. Healthcare. This is common. Oh, sorry. Although cystitis is common in many cases, it is preventable in the healthcare setting. Reducing the use of indwelling urinary catheters is a major prevention strategy. See evidence-based practice box on page 1554. When catheters must be used, strict attention to sterile technique during insertion can reduce the risk for UTIs, as can consistent and adequate perineal and catheter care. See chart 67.1. Catheters should be removed as early as possible. Changes in fluid intake patterns, urinary elimination patterns, and hygiene patterns can help prevent or reduce cystitis in the general population. Teach all people to have a minimum fluid intake of 3 liters daily unless fluid restriction is needed for another health problem. Encourage people to drink more water than sugar-containing drinks. Teach people to avoid urinary stasis by urinating every 3 to 4 hours rather than waiting until the bladder is greatly distended. Encourage everyone either to bathe daily or to thoroughly wash the perineal and urethral areas daily. Other hygiene measures that specifically reduce the risk of cystitis and other UTIs are listed in chart 69.2. Patient-centered collaborative care, assessment, physical assessment, clinical manifestations. Frequency, urgency, and dysuria are the common manifestations of a UTI, but other manifestations may be present. Urine may be cloudy, foul-smelling, or blood-tinged. Ask the patient about risk factors for UTI during the assessment. For non-infectious cystitis, the pelvic pain and urgency/frequency patient syndrome scale, or PUF, can identify patients with interstitial cystitis. Evidence-based practice. Take it out, remove it. One large tertiary care center examined its practices for insertion, maintenance, and removal of indwelling urinary catheters in the incidence of urinary tract infections among its patient population. The examination revealed that often catheters were placed in the emergency department automatically with no written prescription and no further evaluation of purpose. Other findings included that 41.5% of patients with indwelling catheters had no appropriate reason for catheter use. Only 67% had a physician's prescription, and catheter insertion, 64% were not removed until the day of hospital discharge, and 40% had UTI manifestations. Based on catheter use limitations common in long-term care, a team of nurses implemented a pilot program to change practice regarding indwelling catheter use. The pilot program lasted 2 weeks and included a cohort of 35 patients with indwelling catheters who were similar to a cohort group of 34 patients with catheters on whom information was obtained immediately preceding the implementation of the limited use protocol. The major intervention was that nurses were asked to evaluate patients with indwelling catheters and to request an order for removal if the use of the catheter did not meet established critical reasons. As a result of this intervention, documentation of catheter insertion and removal greatly increased. The percent of patients with UTI manifestations was reduced to 13%, and only 6% of patients still had catheters in place on the day of discharge. Level of evidence. The study was a well-designed cohort study with randomization, commentary, implications for practice and research. In addition to having positive results for a reduction of UTIs, the study pointed out problems with the lack of prescriptions of indwelling catheter insertion and removal, along with the sense of tradition rather than proven need for the continued use of indwelling catheters. The dramatic results of this intervention in terms of both reduction of UTIs and reduction in the practice of not removing catheters until day of discharge provide further support for the existing evidence that indwelling catheters are overused and misused. Similar studies with larger samples are needed to continue to provide broader-based support for limiting the use of indwelling catheters. In addition, educating physicians and nurses to think critically about the insertion and maintenance of indwelling catheters is key to the successful outcome of reducing the incidence of hospital-acquired UTIs. Chart 69.2, Patient and Family Education Guide Preventing a Urinary Tract Infection. Drink at least 2 to 3 liters of fluid every day. Be sure to get enough sleep, rest, and nutrition daily. For women, clean your perineum, the area between your legs, from front to back. For women, avoid using or wearing irritating substances such as bubble bath, nylon underwear, and scented toilet tissue. Wear loose-fitting cotton underwear. Granny pants. For women, empty your bladder before and after intercourse. If you experience burning when you urinate, if you have to urinate frequently, or if you find it difficult to begin urinating, notify your physician or other healthcare provider right away, especially if you have a chronic medical condition such as diabetes or are pregnant. Empty your bladder as soon as you feel the urge to urinate. Empty your bladder regularly, every 4 hours, even if you do not feel the urge to urinate. You may try these home therapies: cranberry juice, pure, 50 milliliters daily; apple cider vinegar, 2 tablespoons 3 times daily in juice; vitamin C, 500 milligrams daily to acidify the urine. To prevent recurrent infection, take your antibiotic or other drugs as directed, even after the symptoms go away, and schedule a follow-up appointment for 10 to 14 days after you finish taking the drug. At your follow-up visit, another urine sample may be taken for analysis or culture. Before performing the physical assessment, ask the patient to void. Okay, now we're back to the text, and we're talking about collaborative care, physical assessment, clinical manifestations. Okay, so before performing the physical assessment, ask the patient to void so that the urine can be examined and the bladder emptied before palpation. Assess vital signs to rule out sepsis, inspect the lower abdomen, and palpate the urinary bladder. Distension after voiding indicates incomplete bladder emptying. Using standard precautions, record any lesions around the urethral meatus and vaginal opening. To help differentiate between a vaginal and a urinary tract infection, note whether there is any vaginal discharge. Vaginal discharge and irritation are more indicative of vaginal infection. Women often report burning with urination when normal acidic urine touches labial tissues that are inflamed or ulcerated by vaginal infections or sexually transmitted diseases. Maintain privacy with drapes during this examination. The prostate is palpated by rectal examination for size, change in shape or consistency, and tenderness. The physician or advanced practice nurse performs the rectal prostate assessment. Laboratory assessment. Laboratory assessment for a UTI is a urinalysis with testing for leukocyte esterase and nitrate. The combination of a positive leukocyte esterase and nitrate is 68 to 88% sensitive in the diagnosis of a UTI. Although a urine analysis can include a microscopic count of bacteria, white blood cells, and red blood cells, this additional testing is more expensive, is time-consuming, and may not improve diagnostic accuracy. The presence of more than 20 epithelial cells, high-power field HPF, suggests contamination. The presence of 100,000 colonies per milliliter, or the presence of 3 or more WBCs or pyuria with RBCs, hematuria, indicates infection. Okay, so chart 69.3, key features: urinary tract infection, common clinical manifestations, frequency, urgency, dysuria, hesitancy or difficulty in initiating urine stream, low back pain, nocturia, incontinence, hematuria, pyuria, bacteriuria, retention, suprapubic tenderness or fullness, and feeling of incomplete bladder emptying. Rare clinical manifestations: fever, chills, nausea or vomiting, malaise, flank pain. Clinical manifestations that may occur in the older adult. The only symptom may be something as vague as increasing mental confusion or frequent unexplained falls. A sudden onset of incontinence or a worsening of incontinence may be the only symptom of an early UTI. Fever, tachycardia, tachypnea, and hypotension, even without any urinary symptoms, may be signs of urosepsis. Loss of appetite, nocturia, and dysuria are common symptoms. UTI, urinary tract infection. Okay. A urinalysis is performed on a clean catch midstream specimen. If the patient cannot produce a clean catch specimen, you may need to obtain the specimen with a small diameter 6 French catheter for a routine urinalysis. 10 milliliters of urine is needed. Smaller quantities are sufficient for culture. Okay. A urine culture confirms the type of organism and the number of colonies. Urine culture is expensive and results take at least 48 hours. It is indicated when the UTI is complicated or does not respond to usual therapy or the diagnosis is uncertain. A UTI is confirmed when more than 10 to the 5th colony-forming units are in the urine from any patient. In patients who have symptoms of UTI, as few as 10 to the 3rd colony-forming units may allow the diagnosis to be made. The presence of many different types of organisms in low colony counts usually indicates that the specimen is contaminated. Sensitivity testing follows culture results when complicating factors are present, e.g. stones or recurrent infection. When the patient is older or to ensure the appropriate antibiotics are prescribed. Okay. Occasionally the serum WBC count may be elevated, with the differential WBC count showing a left shift. This shift indicates that the number of immature WBCs is increasing in response to the infection. As a result, the number of bands or immature WBCs is elevated. Left shift often occurs with urosepsis and rarely occurs with uncomplicated cystitis, which is a local rather than a systemic infection. Other diagnostic assessment. The diagnosis of cystitis is based on the history, physical examination, and laboratory data. If urinary retention and obstruction of urine outflow are suspected, urography, abdominal sonography, or CT may be needed to locate the site of obstruction or the presence of calculi. Avoiding cystourothrography is needed when ureteral reflux is suspected. Cystoscopy, Chapter 68, may be performed when the patient has recurrent UTIs, more than 3 or 4 a year. A urine culture is performed first to ensure no infection is present. If infection is present, the urine is sterilized with antibiotic therapy before the procedure to reduce risk for sepsis. Cystoscopy identifies abnormalities that increase the risk of cystitis. Such abnormalities include bladder calculi, bladder diverticula, urethral strictures, foreign bodies, e.g. sutures from previous surgery, and trabeculation, and abnormal thickening of the bladder wall caused by urinary retention and obstruction. Retrograde retrograde pylography, along with a cystoscopic examination, shows outlines and images of the drainage tract. Areas of obstruction or malformation and the presence of reflux are then identified early. Cystoscopy is needed to accurately diagnose interstitial cystitis. A urine analysis usually shows WBCs and RBCs, but no bacteria. Common findings in interstitial cystitis are a small capacity bladder, the presence of Hunner's ulcers or a type of bladder lesion, and small hemorrhages after bladder distension. That's having to do with interstitial cystitis. Okay, common nursing diagnoses and collaborative problems. Nursing diagnoses and collaborative problems that may apply to patients with cystitis include acute pain related to bladder spasms, deficient knowledge, risk factor for cystitis, and drug regimen related to information misinterpretation or unfamiliarity with information resources, urge urinary incontinence related to irritation of bladder or stretch receptors causing spasm, e.g. bladder infection. Risk for impaired skin integrity related to moisture from incontinence. And risk for sepsis. Interventions, non-surgical management, drug therapy. What happened to risk for falls? But whatever. Okay. Interventions, non-surgical management, drug therapy. Drugs used to treat bacteriuria and promote patient comfort include urinary antiseptics or antibiotics, analgesics, and antispasmodics. Cure of a UTI depends on the antibiotic level achieved in the urine, Chapter 69.4. Antifungal agents are prescribed for that was chart 69.4. Antifungal agents are prescribed for fungal infections. Amphotericin B is most often given in daily bladder installations, and ketoconazole or Nizoral is given orally. Antispasmodic drugs decrease bladder spasm and promote complete bladder emptying. Antibiotic therapy is used for bacterial UTIs, see chart 69.4. Guidelines indicate that a 3-day course of trimethoprim or sulfamethoxazole or phosphomycin is effective in treating uncomplicated community-acquired UTIs in women. Single-dose therapy with long-acting fluoroquinolones is being studied. The shorter courses increase adherence and reduce cost. Longer antibiotic treatment, 7 to 21 days, is required for hospitalized patients. Those with complicating factors such as pregnancy, indwelling catheters or stones, and those with diabetes or immunosuppression. Chart 69.4, common examples of drug therapy. Urinary tract infections. Drug dosage, antimicrobials, sulfonamides. Trimethoprim or sulfamethoxazole, Bactrim, Bacterate or Septra, Sulfatrim, Sulfex, Soltrex, Rubac, 60 milligrams of Bactrim, 800 milligrams, blah, 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 blah. Purpose action be to drug reduces bacteria in the urinary tract by direct killing trimethoprim and by inhibiting bacterial reproduction. The sulfamethoxazole, whatever. Sulfamethoxazole. Jesus, that's a terrible word. Okay, so it's a synergistic between Bactrim and whatever, the sulfatrim. One reduces the bacteria, one inhibits the bacterial reproduction. Nursing interventions. Ask patients about drug allergies, especially to sulfa drugs, before beginning drug therapy. Teach patients to drink a full glass of water with each dose and to have an overall fluid intake of at least 3 liters daily. Teach patients to keep out of the sun or to wear protective clothing outdoors and use a sunscreen. Caution patients to complete the drug regimen even if the symptoms improve or disappear sooner. Rationales: allergies to sulfa drugs are common and require changing the drug therapy. Sulfamethoxazole can form crystals that precipitate in the kidney tubules. Fluid intake prevents this complication. This drug increases skin sensitivity to the sun and can lead to severe sunburns even in darker skinned patients, and not completing the drug regimen can lead to infection recurrence and to bacterial drug resistance. There's quinolones, Cipro or Proquin, also gadafloxacin and Zymar. Drugs from this class reduce bacteria in the urinary tract by direct killing bactericidal actions and by inhibiting bacterial reproduction, bacteriostatic actions. Teach patients taking the extended release drugs to swallow them whole, not to crush or chew the tablets. Crushing or chewing the tablet releases all the drug at once, ruining the extended effect. Warn patients not to take the drug within 2 hours of taking an antacid, and acids, especially those containing magnesium or aluminum, interfere with drug absorption. Teach patients how to take their pulse, to monitor it twice daily while on this drug, and to notify the prescriber if new onset irregular heartbeat occurs. This class of drug can induce serious cardiac dysrhythmias. Teach patients to keep out of reach of the sun, or to keep out of the sun, and to wear protective clothing outdoors and use sunscreen. Most quinolones increase skin sensitivity to the sun, can lead to severe sunburns even in darker skinned patients. Caution patients to complete the drug regimen even if the symptoms improve or disappear sooner. Not completing the drug regimen can lead to an infection recurrence and to bacterial drug resistance. And there's some med alerts for quinolone, Cipro. Let's see. Do not confuse Tequin with Tegretol, an oral anticonvulsant, or with Ticlid, a platelet inhibitor. Levofloxacin or Levaquin, 25 milligrams or 250 milligrams orally daily. Okay. These are some of the other ones: Levaquin, Noroxin, and Maxaquin, and Levaquin. And med alerts on those: do not use Noroxin with Neurontin, an oral anticonvulsant. In Ofloxacin, or don't confuse Noroxin with Neurontin. Okay, don't confuse Noroxin with Neurontin. And Floxin, okay, that's it. Some other ones are Ofloxacin or Floxin, and Sparfloxacin or Zagam, other quinolones. Penicillins: amoxicillin, 500 milligrams orally, every 12 hours. Amoxicillin, also with clavulonate, synergistic thing. Clavulin. Drugs from this class reduce bacteria in the urinary tract by direct killing bactericidal actions as a result of interrupting bacterial cell wall synthesis. Ask patient about drug allergies to penicillin before beginning drug therapy. Allergies to penicillin are common and require changing the drug therapy. Teach patients to take the drug with food. Taking it with food reduces the risk of GI upset. Instruct patients to call the prescriber if severe watery diarrhea develops. A complication of penicillin therapy is pseudomembranous colitis, which may require discontinuing the drug. Suggest that women who take oral contraceptives use an additional method of birth control while taking this drug. Penicillin appears to reduce the effectiveness of estrogen-containing oral contraceptives. Caution patients to complete the drug regimen even if the symptoms improve or disappear sooner. Not completing the drug regimen can lead to infection recurrence and to bacterial drug resistance. Oh my God, there's more. Never ends here. Cephalosporins. Duracef, 1,000 milligrams orally every 12 hours. Cefixime or Suprax. Drugs from this class reduce bacteria in the urinary tract by direct killing bactericidal actions as a result of interrupting bacterial cell wall synthesis. Ask about drug allergies to penicillin or cephalosporins before beginning drug therapy. Drugs in this class are structurally similar to penicillin. Anyone with allergies to penicillin is likely to be allergic to cephalosporins. Instruct patients to call the prescriber if severe watery diarrhea develops. A complication of penicillin therapy is pseudomembranous colitis, which may require discontinuing the drug. Caution patients to complete the drug regimen even if symptoms improve, blah, blah, blah. Not completing the drug, blah, blah, blah. You know that part. Phosphomycin or Monorol, 3 grams orally as a one-time dose. Damn, 3 grams. This drug reduces, I guess this is 3,000, but whatever. Okay, this drug reduces bacteria in the urinary tract by direct killing as a result of interrupting bacterial cell wall synthesis. This is still a penicillin, though. Instruct patients to mix the contents of the package in about a half cup of cold water, stir well, and drink all the liquid. This oral drug is available in granules that must be dissolved before taking. Avoid taking this drug when also taking metoclopramide or any other drug that increases GI motility. Drugs that increase GI motility reduce the absorption of phosphomycin. Then there's urinary antiseptics. Nitrofurantoin or furidantin, macrobid, macrodantin, Nephrinex, Urotoin, 100 milligrams orally every 12 hours. These are urinary antiseptics. Drug from this class usually reduce bacteria in the urinary tract by inhibiting bacterial reproduction. They're bacteriostatic actions. Teach patients to shake the bottle well before measuring the drug. Suggest that patients obtain a calibrated spoon for liquid drugs and do not use household spoons. Okay, rationales over there. Drug is a suspension and requires shaking to ensure homogeneity, and household spoons are not accurate accurate for measuring drugs. Teach patients to drink a full glass of water with each dose and to have an overall fluid intake of at least 3 liters a day. Drug precipitates in the kidney tubules and damages the kidney. Fluid intake prevents this complication. Caution patients to complete the drug regimen even if the symptoms improve or disappear sooner. Not completing the drug regimen can lead to an infection recurrence into bacterial drug resistance. Then there's bladder analgesics. Phenazopyridine or azodine, prodium, pyridiate, whatever, pyridium, Urostat, Fenazo, 200 milligrams orally 3 times daily after meals. Drug reduces bladder pain and burning on urination by exerting a topical analgesic or local anesthetic effect on the mucosa of the urinary tract. Remind patients that this drug will not treat an infection, only the symptoms. Teach patients to take the drug with or immediately after a meal. Warn patients that urine will turn red or orange. Drug does not have any antibacterial actions. Food reduces the risk of GI disturbances, and the red or orange urine is an expected response to this drug. May stain clothing or toilets. And antispasmodics, last ones. Hyoscyamine or anaspaz, cytospaz, many others. 0.125 milligrams to 0.25 milligrams orally, 3 to 4 times daily. Drug relieves bladder spasms by inhibiting nerve stimulation to the bladder muscle. So it relieves bladder spasms by inhibiting nerve stimulation to the bladder muscle. Teach patients to notify the prescriber if blurred vision or other eye problems, confusion, dizziness, or fainting spells, fast heartbeat, fever, or difficulty passing urine occurs. These are manifestations of drug toxicity. Teach patients to wear dark glasses in sunlight and other bright light areas. Drug dilates the pupil and increases eye sensitivity to light. And then there's a note at the end that says trimethoprim can be given alone to patients with a sulfa allergy. So long-term antibiotic therapy is used for chronic recurring infections caused by structural abnormalities or stones. Trimethoprim, 100 milligrams daily, may be used for long-term management of the older adult with frequent UTIs. For women who have recurrent UTIs after intercourse, 1 low-dose tablet of trimethoprim or TMP, also called Proloprim or Trimpex, or TMP with sulfamethoxazole, half or single strength Bactrim, or nitrofurantoin, macrodantin, after intercourse is often prescribed. Estrogen used as an intravaginal cream may prevent recurrent UTIs in the postmenopausal woman, although this therapy is controversial. Urinary elimination management. The goal is to maintain an optimal urinary elimination pattern. Nursing interventions for the management of cystitis focus on comfort and teaching about therapy and prevention measures. Women's health considerations. Pregnant women with a bacterial UTI require prompt and aggressive treatment because simple cystitis can lead to acute pyelonephritis during pregnancy. Pyelonephritis in pregnancy can cause preterm labor and adversely affect the fetus. Nutrition therapy. The diet should include all food groups and include more calories for the increased metabolism caused by infection. Urge patients to drink enough fluid to maintain diluted urine. throughout the day and night unless fluid restriction is needed for another health problem. The daily drinking of 50 milliliters of concentrated cranberry juice appears to decrease the ability of bacteria to adhere to the epithelial cells lining the urinary tract, decreasing the incidence of systematic UTIs in some patients. Cranberry juice must be consumed for 3 to 4 weeks to be effective, and the efficacy of cranberry tablets has not been established. It is important to note that cranberry juice is an irritant to the bladder with interstitial cystitis and should be avoided by patients with this condition. Avoid caffeine. Carbonated beverages and tomato products may decrease bladder irritation during cystitis. Now, avoiding caffeine, carbonated beverages, and tomato products may decrease bladder irritation. Okay. Comfort measures. A warm sitz bath taken 2 to 3 times a day for 20 minutes may provide comfort and some relief of local symptoms. If burning with urination is severe or urinary retention occurs, teach the patient to sit in the sitz bath and urinate into the warm water. Oh boy. Yum. Great. Surgical management. Surgery for cystitis treats the conditions that increase the risk for recurrent UTIs, e.g., removal of obstructions and repair of vesicoureteral reflux. Procedures may include cystoscopy, see Chapter 68, to identify and remove calculi or obstructions. Community-based care. Assess the patient's level of understanding of the problem. His or her knowledge about factors that promote the development of cystitis determines the type of teaching interventions planned. Teach the patient how to take prescribed drugs. Stress the need for correct spacing of doses throughout the day and the need to complete all the prescribed drugs. If the drug will change the color of the urine, as it does with phenazopyridine, inform the patient to expect this change. Offer techniques for remembering the drug schedule, such as the use of a daily calendar or the association of drugs with usual activities, e.g., meal times. Patients with associate symptoms of discomfort with sexual activities patients may associate symptoms of discomfort with sexual activities and have feelings of guilt and embarrassment. Frank and sensitive discussions with a woman who has recurrences of UTIs after sexual intercourse can help her find techniques to handle the problem. See Chart 69.2. Explore with her the factors that contribute to her infections, such as diaphragm use and her general resistance to infection. Remind the patient that vigorous cleaning of the perineum with harsh soaps and vaginal douching may irritate the perineal tissues and increase the risk for UTI. At the patient's request, discuss the problem with her and her partner to help them find ways of maintaining their intimate relationship. Decision-making challenge, coordination of care. The patient is a 24-year-old woman with a history of type 1 diabetes mellitus for the past 10 years. She is 2 days postpartum after an emergency C-section. She was 34 weeks pregnant and had difficulties throughout her pregnancy with hypertension. During the delivery, a Foley catheter was inserted to help manage fluid balance. Her Foley catheter was removed last night. She reported burning during her first void about 4 hours after the Foley was removed. Today, with her second void, she continues to describe pain on urination. Her urine is pink-tinged, cloudy, and straw-colored. Current vital signs are temperature 97.8, pulse 88, respirations 12, BP 142/88. Morning laboratory test results included a CBC, a CBC with normal values, including a white blood cell count of 9,600. Her basic metabolic panel was normal, with a BUN of 13 milligrams per deciliter and a creatinine of 1.0 milligrams per deciliter. So, what risk factors are present in this patient related to a urinary tract infection? What other assessment data should you obtain and why? What interventions will you teach her to comfort and treatment of this infection? And she asks if this means her kidneys will be harmed. She knows as a diabetic she is already at risk for nephropathy, As you respond, what level of language will you use? What level of language? I don't know. Alright. So that was cystitis. Okay, on to 1570 to 1575, nephrolithiasis or urolithiasis, pathophysiology, renal stone. Urolithiasis is the presence of calculi or stones in the urinary tract. Stones often do not cause symptoms until they pass into the lower urinary tract, where they can cause excruciating pain. Nephrolithiasis is the formation of stones in the kidney. Formation of stones in the ureter is uretolithiasis. Urologic stones are caused by many disorders. However, the exact mechanism of stone formation is not entirely understood. Everyone excretes crystals in the urine at some time, but fewer than 10% of people form stones. About 75% of stones contain calcium as one part of the stone complex, which may be calcium oxalate or calcium phosphate. Struvite, 15%, and uric acid, 8%, and cysteine, 3%, make up the less common stones. Formation of stones seems to involve three conditions. Slow urine flow, resulting in supersaturation of the urine with a particular element, e.g. calcium, that first becomes crystallized and later becomes the stone. Damage to the lining of the urinary tract, e.g. abrasion from crystals. Decreased inhibitor substances in the urine that would otherwise prevent supersaturation and crystal aggregation, high urine acidity, as with uric acid and cysteine stones, or alkalinity, as with calcium phosphate and struvite stones, as well as drugs, as with triamterene, indinavir, and acetazolamide, contribute to stone formation. One example of a metabolic problem causing stone formation begins when excessive amounts of calcium are absorbed through the intestinal tract, the most common cause of hypercalciuria. Excessive calcium. As blood circulates through the kidneys, the excess calcium is filtered into the urine, causing supersaturation of calcium in the urine. If fluid intake is poor, such as when a patient is dehydrated, supersaturation is more likely to occur, and the risk for calculum combine with another compound to form a larger molecule, or the risk for calcium combining with another compound to form a larger molecule increases. Calcium complexes often serve as a center for other deposits, and eventually a stone forms. Stones that form in the kidney and then pass into the ureter often lodge in areas where the ureter bends or slightly changes shape. When the stone occludes the ureter and blocks the flow of urine, the ureter dilates. Enlargement of the ureter is called hydroureter. Chart 6910, Patient and Family Education Guide. Urinary incontinence. Maintain a normal body weight to reduce the pressure on your bladder. Do not try to control your incontinence by limiting your fluid intake. Adequate fluid intake is necessary for kidney function and health maintenance. If you have a catheter in your bladder, follow the instructions given to you about maintaining the sterile drainage system. If you are discharged with a suprapubic catheter in your bladder, inspect the entry site for the tube daily. Clean the skin around the opening gently with warm soap and water, and place a sterile gauze dressing on the skin around the tube. Report any redness, swelling, drainage, or fever to your physician. Do not put anything into your vagina, such as tampons, drugs, hygiene products, or exercise weights. That's new. Until you check with your physician at your 6-week checkup after surgery. Do not have sexual intercourse until after your 6-week post-operative checkup. Do not lift or carry anything heavier than 5 pounds or participate in any strenuous exercise until your physician gives you post-operative clearance. In some cases, this could be as long as 3 months. Avoid exercise such as running, jogging, step, or dance aerobic classes, rowing, cross-country, ski, or stair climbing machines, and mountain biking. Brisk walking without any additional hand, leg, or body weights is allowed. Swimming is allowed after all drains and catheters have been removed and your incision is completely healed. If Kegel exercises are recommended, ask your nurse for specific instructions. The pain associated with ureteral spasm is excruciating and may cause the patient to go into shock from stimulation of nearby nerves. In addition, hematuria or bloody urine may result from damage to the urethral lining. If the obstruction is not removed, urinary stasis can cause infection and impair kidney function on the side of blockage. As the blockage persists, hydronephrosis, or enlargement of the kidney caused by blockage of urine lower in the tract and filling of the kidney with urine, and kidney damage may develop. Etiology and genetic risk. The cause of urolithiasis is unknown. At least 90% of patients who form stones have a metabolic risk factor. Table 69.5 lists some metabolic defects that commonly cause stone formation. A diet high in calcium is not believed to cause stones unless a metabolic defect or renal tubular defect already exists. Data suggests that a normal calcium diet that is relatively low in animal protein, salt, or both may be effective in preventing stone formation. A low calcium diet does not prevent stone formation. Urinary stasis, urinary retention, immobility, and dehydration all increase the risk for stones to form, except for the use of thiazides for calcium oxalate stones. Diuretics can cause volume depletion and thus may promote the formation of stones. Genetic considerations. More than 30 genetic variations are associated with the formation of renal stones. Single gene disorders are rare. More commonly, nephrolithiasis is a complex disease with genetic variation in intestinal calcium absorption, renal calcium transport, or renal phosphate transport, all associated with stone formation. Always ask a patient with renal stone whether other family members have also had this problem. Incidence Prevalence. The incidence of stone disease is high and varies with geographic location, race, and family history. About 12% of adults will have at least one episode of renal stone disease. The incidence is higher in men. However, struvite stones are twice as common in women. Recurrence rates vary depending on the type of treatment. The recurrence rate of untreated calcium oxalate stones is 35% to 50% in 5 to 10 years. A higher recurrence of stones occurs in patients with a family history of stone disease and in those who had their first occurrence by age 25 years. Cultural awareness. The incidence of stone disease is most common in the southeastern United States, Japan, and Western Europe. Calcium stone disease is more common in men than in women and tends to occur in young adults or during early middle adulthood. Kidney stone disease occurs more often in younger adults than older adults and more commonly among white people. For patients in these higher risk groups, nursing care should include teaching family members as well as patients about the manifestations of a stone and interventions to reduce stone formation. Okay. About a personal or family history of urologic stones. Obtain a diet history, including fluid intake patterns. If he or she has a history of stone formation, ask about past treatment, whether chemical analysis of the stone was performed, and what preventative measures were followed. The major manifestation of stones is severe pain, commonly called renal colic. Flank pain suggests that the stone is in the kidney or upper ureter. Flank pain that extends toward the abdomen or to the scrotum, testes, or the vulva suggests that stones are in the ureters or bladder. Pain is most intense when the stone is moving or when the ureter is obstructed. Renal colic begins suddenly and is often described as unbearable. Nausea, vomiting, pallor, and diaphoresis often accompany the pain. A large stationary stone in the kidney or staghorn calculus, however, rarely causes much pain because it is not moving. Frequency and dysuria occur when a stone reaches the bladder. Oliguria or scant urine output or anuria, absence of urine output, suggests obstruction, possibly at the bladder, neck, or urethra. Urinary tract obstruction is an emergency and must be treated immediately to preserve kidney function. Table 69.5. metabolic defects that commonly cause calculi. Hypercalcemia, primary, absorptive, increased intestinal calcium absorption. Renal, decreased renal tubule excretion of calcium. Resorptive would be parathyroidism, vitamin D intoxication. Secondary, renal tubule acidosis, prolonged immobilization. And then next would be hyperoxaluria. Primary, genetic, autosomal recessive trait resulting in high oxalate production. Dietary, excess oxalate from foods such as spinach. Secondary, rhubarb, Swiss chard, cocoa, beets, wheat germ, pecans, peanuts, okra, chocolate, and lime peel. Hyperuricemia, primary, gout is an inherited disorder of purine metabolism. 20% of patients with gout have uric acid calculi. Increased production or decreased clearance of purine. Secondary, from myeloproliferative disorders, thiazide diuretics, and carcinoma. Struvite, made of magnesium, ammonium phosphate, and carbonate apatite, formed by urea splitting by bacteria, most commonly Proteus mirabilis, and needs an alkaline urine to form. And cystinuria, autosomal recessive defect of amino acid metabolism that precipitates insoluble cystine crystals in the urine. Okay. Back to the text. Examine the patient to detect bladder distension. The patient may appear pale, ashen, and diaphoretic, and suffer from excruciating pain. Vital signs may be moderately elevated with pain. Body temperature and pulse are elevated with infection. Blood pressure may decrease if the severe pain causes shock. Urinalysis is performed in patients with suspected calculi. Hematuria is a common finding. Blood may make the urine appear smoky or rusty. RBCs are usually caused by stone-induced direct trauma on the lining of the ureter, bladder, or urethra. WBCs and bacteria may be present as a result of urinary stasis. Increased turbidity or cloudiness and odor indicate the infection may also be present. Microscopic examination of the urine may identify crystals from which stones could form. Urinary pH is measured to determine acidity or alkalinity. The serum WBC count is elevated with infection. Increases in the serum calcium, serum phosphate, or serum uric acid levels indicate excess minerals are present and may contribute to stone formation. Stones are easily seen on X-rays of the kidneys, ureters, and bladder, cub, IV urograms, or computed topography. Non-contrast helical CT has the highest sensitivity for the identification of urinary tract stones. These procedures confirm the presence and location of the stones. IV urography is useful for identifying whether the urinary tract is obstructed. However, because of the risk of acute renal failure induced by contrast dye, other diagnostic tests may be chosen for high-risk patients. Older adults and patients with diabetes mellitus, multiple myeloma, or elevated serum creatinine levels would be high-risk patients. Don't do the urography. Renal ultrasonography creates images from sound waves, structures of varying density. Therefore, the images of stones are clear. Small stones are harder to identify and locate. Ultrasound is the main method used to identify hydronephrosis from any cause. Okay. Interventions. Nursing interventions focus on pain management and prevention of infection and urinary obstruction. Most patients can expel the stone without the invasive procedures. The most important factors regarding whether a stone will pass on its own are are its composition, size, and location. The larger the stone and the higher up in the urinary tract it is, the less likely it is to be passed. Other interventions may be needed when the patient does not pass the stone spontaneously. Pain relief measures. Non-surgical and surgical approaches are used to assist the patient with a kidney stone achieve an acceptable degree of pain relief. Non-surgical management. Non-surgical measures to relieve pain include strategies to enhance stone passing as well as direct management. Drug therapy is needed most in the first 24 to 36 hours when pain is most severe. Opioid analgesics are often needed to control the severe pain caused by stones in the urinary tract. Opioid agents such as morphine are often given IV for rapid pain relief. NSAIDs such as ketorolac or Toradol in the acute phase may be quite effective. When NSAIDs are used, the risk for bleeding is increased, and the use of extracorporeal shockwave lithotripsy must be delayed. Control of pain is more effective when the drugs are given at regularly scheduled intervals or by a constant delivery system, e.g. skin patch instead of PRN. Spasmolytic drugs such as oxybutynin chloride or ditropan and propanethylene bromide or probanthine or propanthel are important for the relief and control of the pain. See chart 69.8. Give the drugs and assess the response by asking the patient to rate the discomfort on a pain rating scale. Complementary and alternative therapies with relaxation techniques such as hypnosis and imagery, therapeutic or healing touch, and acupuncture can relieve pain. Patients often have difficulty finding a comfortable position in which to relax, thus assisting the patient with positioning can often aid in pain reduction. Breathing techniques such as those used in childbirth can also help him or her relax. Other malignant techniques or other management techniques include avoiding overhydration and underhydration in the acute phase to help make the passage of a stone less painful. Strain the urine and teach the patient to strain it to monitor for stone passage. Send any stone passed to the laboratory for analysis because preventative therapy is based on stone composition. Lithotripsy, also known as extracorporeal shockwave lithotripsy, ESWL, is the use of sound, laser, or dry shockwaves to break the stone into small fragments. The patient receives conscious sedation and lies on a flat table with the lithotripter aimed at the stone, which is located by fluoroscopy. A long anesthetic cream is applied to the skin site over the stone 45 minutes before the procedure. During the procedure, cardiac rhythm is monitored by ECG, and the shock waves are delivered in synchrony with the R wave. About 500 to 1,500 shock waves are applied in 30 to 45 minutes. Continuous ECG monitoring for dysrhythmia and fluoroscopic observation for stone destruction are maintained. After lithotripsy, strain the urine to monitor the passage of the stone fragments. Bruising may occur on the flank of the affected side after ESWL. Occasionally a stent is placed in the ureter before ESWL to ease passage of the stone fragments. Cystine stones are often resistant to ESWL. Surgical management. Medical and surgical procedures are used if urinary obstruction occurs or if the stone is too large to be passed. Minimally invasive surgical procedures. Minimally invasive surgical procedures, MIS procedures, include stenting, retrograde uretoscopy, and percutaneous uretolithotomy and nephrolithotomy. Stenting is performed with a stent, a small tube that is placed in the ureter by uretoscopy. Uretoscopy. The stent dilates the ureter and way for the stone or stone fragments. This procedure prevents the passing stone from coming in contact with the ureteral mucosa, thereby reducing pain, bleeding, and infection risk, all of which could block the ureter. A Foley catheter may be placed to facilitate passage of the stone through the urethra. Retrograde ureteroscopy is an endoscopic procedure. The ureteroscope is passed through the urethra and bladder into the ureter. Once the stone is seen, it is removed using grasping baskets, forceps, or loops. Lithotripsy also can be performed through the ureteroscope. A Foley catheter may be placed to facilitate passage of the stone fragments through the urethra. Insertion of the Foley catheter. Percutaneous uretolithotomy and nephrolithotomy is the removal of a stone in the ureter or kidney through the skin. Percutaneous uretolithotomy and nephrolithotomy is the of a stone lies prone or on the side and receives local or general anesthetic. The physician identifies the ideal entry point with fluoroscopy and then passes a needle into the collecting system of the kidney. Once a tract has been made in the kidney, other equipment such as an intercorporeal or inside the body ultrasonic or laser lithotripter can be used to break up and remove the stone. An endoscope with a to grasp and extract the stone can be used. Often a nephrostomy tube is left in place at first to prevent the stone fragments from passing through the normal urinary tract. Provide routine nephrostomy tube care and monitor the patient for complications after the procedure. Complications include bleeding at the site or through the tube, thorax, and infection. Often open surgical procedures have failed or with risk of the ureter are possible. An open uretolithotomy into the ureter, pylolithotomy into the kidney pelvis, or nephrolithotomy into the kidney procedure may be performed. These procedures are used for a large or for the selected procedure by examining how, when, and where the procedure will be performed. Describe what he or she can expect to see, hear, and feel before and after the procedure. The patient is given nothing by mouth and also receives a bowel preparation before the procedure. See Chapter 3. Operative procedures. The retroperitoneal area is entered through a large flank incision or as nephrectomy. See Chapter 70. Pylolithotomy or nephrolithotomy, and through a lower abdominal incision or uretolithotomy. The urinary tract is entered surgically and the stone is removed. Before closure, tubes and drains may be placed, e.g. nephrostomy tube, ureteral stent, Penrose or other wound drainage device, and Foley catheter. Postoperative dietary changes. Control infections before invasive procedures is critical for the prevention of urosepsis. Interventions include giving appropriate or to prevent Keflexin, Novalexin, or Cephalexin first prescribed for stone disease. The broad coverage against gram-negative organisms. After the results of the culture and sensitivity studies are obtained, more specific antibiotics may be prescribed. Culture and sensitivity studies are often done 48 hours of antibiotic therapy, and again 48 hours of the prescribed course of therapy. While awake in 750 milliliters at night, and the and prevents the cystine crystals from forming. Back to the text. Levels may ensure that adequate levels have been reached. If the desired blood level of these antibiotics is exceeded, toxic effects and kidney damage may result. If the blood level of the antibiotic evidence of of obstruction measures to prevent urinary depends on what is causing stone formation in the type for side effects. thereby reducing calcium loads. Okay, orthophosphates alter calcium phosphorus metabolism, resulting in decreased urine saturation of calcium oxalate. Sodium cellulose phosphate reduces intestinal absorption of calcium. Okay, for patients with hyperoxaluria, high levels of oxalic acid in the urine, allopurinol or Xyloprim, and vitamin B6, pyridosine, are used. For patients with chronic gout, allopurinol helps prevent the formation of urate or uric acid stones. To alkalinize the urine, drugs such as potassium citrate, 50% sodium citrate, and sodium bicarbonate are used. The desired urine pH is 6 to 6.5 because the normal urine pH is 5 to 6, and desired values are termed alkaline. For patients with cystinuria, high levels of cysteine in the urine, both alpha mercaptopropionylglycine, or AMPG, and captopril, or capotin, lower urine cysteine levels. They are used when hydration and urine alkalization have not been successful. Nutrition therapy depends on the type of stone formed, Table 69.6. Collaborate with the nutritionist to plan the appropriate diet for the patient. Chart 69.11, Patient Family Guide, Urinary Calculi. Finish your entire prescription of antibiotics to ensure that you will not get a urinary tract infection. You may resume your usual daily activities. Remember to balance regular exercise with sleep and rest. You may return to work 2 days to 6 weeks after surgery, depending on the type of intervention, your personal tolerance, and your physician's directives. Depending on the type of stone you had, your diet may be restricted to prevent further stone formation. Remember to drink at least 3 liters of fluid a day to dilute potential stone-forming crystals, prevent dehydration, and promote urine flow. Monitor urine pH as directed, possibly up to 3 times per day. Expect bruising after lithotripsy. The bruising may be quite extensive and may take several weeks to resolve. Your urine may be bloody for several days after surgery. Pain in the region of the kidneys or bladder may signal the beginning of an infection or the formation of another stone. Report any pain, fever, chills, or difficulty with urination immediately to your physician or nurse. Keep follow-up appointments to check on infection and have repeat cultures done. Other measures can help the patient pass the stone more quickly. Encourage the patient to walk as often as possible. Walking promotes passage of stones and reduces bone calcium reabsorption. Check the urine pH daily and strain all urine with filter paper to collect past stones and fragments. Mining for gold. Health teaching includes the key points listed in Chart 69.11. The patient often has great anxiety and fear that a stone and its pain may reoccur. In addition to anxiety about the pain, the risk for repeated surgical interventions or permanent and serious kidney damage is a major concern. Psychosocial preparation and health promotion activities help prevent reoccurrence. And that was kidney stones. Ow. Okay, on to pages 1590 to 1593. Glomerulonephritis / nephritic syndrome. Okay, immunologic renal disorders. Glomerulonephritis, GN, is the leading cause of end-stage renal disease, ESKD. Whether the disease starts in the kidney or occurs as the result of other health problems, the glomeruli are usually injured, Table 71. For disease that starts in the kidney, a genetic basis and immune problem are common. In addition, systemic diseases and infections can have renal effects and cause glomerular injury. Table 72. Conditions that lead to glomerular disease include systemic lupus, erythematosus, and diabetic nephropathy. Table 71, primary glomerular diseases and syndromes. Acute glomerulonephritis, rapid progressive glomerulonephritis, or RPGN, and chronic glomerulonephritis, also nephrotic syndrome, and persistent vague urinary abnormalities with few or no symptoms. Each type of disease or syndrome has a specific pathophysiology and clinical manifestations. Their glomerular effects are caused by injury to the glomeruli and result in proteinuria, hematuria, and decreased glomerular filtration rate, or GFR, edema, immunologic changes in the glomeruli, interstitium or tubules, and the effects acute or chronic. Both immune responses are involved. The resultant renal disorder can be systemic or confined to the kidneys. Most forms of glomerulonephritis, GN, with immune complexes in the glomeruli. Figure 76. The complex is made up of antigens, or foreign substances in the body, and antibodies. The antibodies of any normal kidney tissue, or it can be dissolved in a body fluid, e.g. the blood. Bacteria and viruses are also antigens. Exposure to bacteria, viruses, drugs, or other toxins is believed to be the trigger for glomerular injury. Antibody reaction with antigens cause immune complexes to form and become deposited in many inflammatory mediators, such as complement, blood cells, and blood clotting protein, damage kidney tissue. Actions that cause tissue injury include damage to cell membranes, local edema, blood cell platelet activation. Acute glomerulonephritis. An infection often occurs before the manifestations of acute GN. The onset of symptoms is about 10 days from the time of infection. Glomerular diseases and syndromes. Systemic lupus erythematosus, or SLE, Schönlein-Henoch purpura, good pastures syndrome, systemic necrotizing vasculitis, Wegener's granulomatosis, periarteritis nodosa, also called amyloidoglomerulopathy syndrome, viral hepatitis B, viral hepatitis C, cirrhosis, sickle cell disease, non-streptococcal post-infectious acute glomerulonephritis, infective endocarditis, uremic syndrome, and thrombotic thrombocytopenia purpura. Most causes of acute GN are infectious, table 73, or are related to other systemic diseases. See table. GN after systemic streptococcal infection is more common in men. Patient-centered collaborative care assessment history. Ask about recent infections, particularly of the skin or upper respiratory tract, and about recent travel or other activities with possible exposure to viruses, bacteria, fungi, or parasites. Recent illnesses, surgery, or other invasive procedures may suggest infections. Ask about any known systemic diseases such as systemic lupus, erythematosus, or SLE, which could cause acute GN. Table 73, infectious causes of acute glomerulonephritis. Group A, beta hemolytic streptococcus, streptococcal or staphylococcal or gram-negative bacteremia or sepsis, pneumococcal mycoplasma or Klebsiella pneumoniae, syphilis, visceral abscesses, infective endocarditis, hepatitis B, infectious mononucleosis, measles, mumps, Rocky Mountain spotted fever, cytomegalovirus infection, histoplasmosis, toxoplasmosis, varicella, chlamydia, tsetse infection, coxsackie infection, any bacterial, parasitic, fungal, or viral infection, potentially. Physical assessment, clinical manifestations. Inspect the patient's skin for lesions or recent incisions, including body piercings. Assess the face, eyelids, hands, and other areas for edema, present in about 75% of patients with acute GN. Assess for fluid overload. Assess the face, eyelids, and hands for areas of edema. 75% of patients have that with GN. Assess for fluid overload and circulatory congestion, which may accompany the sodium and fluid retention occurring with acute GN. Ask about any difficulty in breathing or shortness of breath. Assess for crackles in the lung fields, an S3 heart sound or gallop rhythm, and neck vein distension. Ask about changes in urination pattern and any changes in urine color. Microscopic blood in the urine occurs up to 66% of the time, and patients often describe their urine as smoky, reddish, brown, rusty, or cola-colored. Ask about dysuria or oliguria. Weigh the patient to assess for fluid retention. Take the patient's blood pressure and compare it with the baseline blood pressure. Mild to moderate hypertension often occurs with acute GN as a result of sodium and fluid retention. The patient may have fatigue, a lack of energy, anorexia, nausea, and or vomiting if uremia from kidney failure is present. Considerations for older adults. The less common manifestations of acute GN are more likely to occur in older adults. Circulatory congestion often is present, causing acute GN to be easily confused with congestive heart failure. Laboratory assessment. Urine analysis shows red blood cells or hematuria and protein or proteinuria. An early morning specimen of urine is preferred for urinalysis because the urine is most acidic and formed elements are more intact at that time. Microscopic examination often shows red blood cell casts as well as casts from substances. The urine sediment assay is usually positive. The glomerular filtration rate, GFR, either estimated from a single serum and urine creatinine value or measured by the 24-hour urine test for creatinine clearance, may be decreased to 50 milliliters per minute. Blood urea nitrogen bun levels are usually increased. The older patient may have a greater decline in GFR. So, bun increased, creatinine decreased. A 24-hour urine collection for total protein assay is obtained. The protein excretion rate for patients with acute GN may be increased from 500 milligrams to 3 grams per 24 hours in most patients. How is that an increase? But I got you, grams. Okay, so 3,000 milligrams. Serum albumin levels are decreased because of the protein lost in the urine and because of fluid retention causing dilution. Specimens from the blood, skin, or throat are obtained for culture if indicated. Other serologic tests include anti-streptolysin O titers and C3 competent levels, cryoglobulins or immunoglobulins, GIG, anti-nuclear antibodies or ANAs, and circulating immune complexes, whatever that is. Okay, anti-streptolysin O titers are increased after group A beta hemolytic streptococcus infections. Complement levels are decreased when the complement system is activated. Type 3 cryoglobulins may be found during acute illness. ANAs suggest an autoimmune response, and SLE is just one possibility. Circulating immune complexes contain IgG and C3 are often detected. Boy, I don't know what any of those labs are. I have to look them up. Other diagnostic assessment. A renal biopsy provides a precise diagnosis of the condition, assists in determining the prognosis, and helps outline treatment. See Chapter 68. The specific tissues features are determined by light microscopy, immunofluorescent stains, and electron microscopy to identify cell type, the presence of immunoglobulins, or type of tissue deposits. Okay, interventions. Interventions focus on managing infection, preventing complications, and providing appropriate patient education. Management of infection as a cause of acute GN begins with appropriate antibiotic therapy. Penicillin, erythromycin, or azithromycin is prescribed for GN caused by streptococcal infection. Check the patient's known allergies before giving any drug. To prevent infection spread, antibiotics for people in immediate close contact with the patient also may be prescribed. Stress personal hygiene and basic infection control principles, e.g. hand washing. To prevent spread of the organism, teach patients the importance of completing the entire course of prescribed antibiotic. Prevention of complications is an important nursing intervention. For patients with fluid overload, hypertension and edema, diuretics and a sodium and water restriction are prescribed. Antihypertensive drugs may be needed to control hypertension. See Chapter 38. The usual fluid allowance is equal to 24-hour urine output plus 500 to 600 milliliters. Patients with oliguria usually have increased serum levels of potassium and BUN. Potassium and protein intake may be restricted to prevent hyperkalemia and uremia as a result of the elevated BUN. Okay. Nausea and vomiting or anorexia indicates that uremia is present. Dialysis is necessary if uremic symptoms or fluid volume excess cannot be controlled. Plasmapheresis, removal and filtering of the plasma to eliminate antibodies, also may be attempted. To conserve the patient's energy, assist him or her in maintaining a restful environment, balancing activity and rest, and coordinating needed activities. Urge the patient to practice relaxation techniques and to participate in diversional activities to reduce emotional stress. Patient education includes teaching the patient and family members about the purpose and desired effects of prescribed drugs and dosage and schedule, and potential adverse side effects, and ensure that they understand dietary or fluid restrictions, including methods of detecting fluid retention. Advise the patient to measure weight and blood pressure daily at the same time each day. Instruct him or her to notify the healthcare provider of any sudden increase in weight or blood pressure. If short-term dialysis is required to control fluid volume or uremic symptoms, explain peritoneal or vascular access care and dialysis schedules and routines. Also see Chapter 71. Rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis, or RPGN, a type of acute nephritis, is also called crescentic glomerulonephritis because of the presence of crescent-shaped cells in the bone capsule. RPGN develops over several weeks or months and causes loss of kidney function. Patients become quite ill quickly and have manifestations of renal failure, fluid volume excess, hypertension, oliguria, electrolyte imbalances, and uremic symptoms. The patient may have had previous infection or systemic disease, such as systemic lupus erythematosus (SLE). The renal decline often progresses to end-stage kidney disease (ESKD). Chronic glomerulonephritis pathophysiology. Chronic glomerulonephritis or chronic nephritic syndrome develops over 20 to 30 years or even longer. The exact onset of the disorder is rarely identified. Often the cause of the disease is not known because the kidneys are atrophied and tissue is not available for biopsy or diagnosis. Mild proteinuria and hematuria, hypertension, fatigue, and occasional edema are often the only manifestations. Although the exact cause is not known, changes in the kidney tissue result from hypertension, infections, and inflammation, or poor blood flow to the kidneys. Kidney tissue atrophies and the number of functional nephrons is greatly reduced. Biopsy in the late stages of atrophy may show glomerular changes, cell loss, protein and collagen deposits, and fibrosis of the kidney tissue. Microscopic examination shows deposits of immune complexes. The loss of nephrons reduces glomerular filtration. Hypertension and renal arteriolosclerosis are often present. The glomerular damage allows proteins to enter the urine. Chronic glomerulonephritis always leads to kidney failure. Patient-centered collaborative care, assessment, history. Ask about other health problems, including systemic diseases, renal or urologic disorders, infectious diseases, e.g. streptococcal infections, and recent exposures to infections. Ask about overall health status and whether increasing fatigue and lethargy have occurred. Identify the patient's pattern of voiding. Ask whether the frequency of voiding has increased or the quantity of urine has decreased. Ask about changes in urine color, odor, or clarity, and whether dysuria or incontinence has occurred. Nocturia is also a common symptom. Assess the patient's general comfort and ask whether any dyspnea at rest or with exertion has occurred, because fluid overload can occur with decreased urine output. Ask about and observe for changes in mental functioning, such as irritability or inability to read or perform job-related functions or other process requiring concentration. Changes in memory and the ability to concentrate occur as waste products collect in the blood. Physical assessment, clinical manifestations. Assess for systemic circulatory overload, auscultate lung fields for crackles, observe the respiratory rate and depth, and measure blood pressure and weight. Auscultate the heart for rate, rhythm, and the presence of an S3 heart sound. Inspect the neck veins for venous engorgement and check for edema of the foot and ankle on the shin and over the sacrum. Assess for uremic symptoms such as slurred speech, ataxia, tremors, or astrixis, flapping tremor of the fingers, or the inability to maintain a fixed posture with the arms extended and wrists hyperextended. Inspect skin for yellowish color, texture, bruises, rashes, or eruptions. Ask for itching and document areas of dryness or any excoriation from scratching. Diagnostic assessment. Urine output decreases, but the urine appears normal unless a urinary tract infection also is present. Urinalysis shows protein, usually less than 2 grams in a 24-hour collection. The specific gravity is fixed at a constant level of dilution, around 1.010. Red blood cells and casts may be in the urine. The glomerular filtration rate, GFR, measured by creatinine clearance, is low. The serum creatinine level is elevated, usually greater than 6 milligrams per deciliter, but maybe as high as 30 milligrams per deciliter or more. The bun is increased often as high as 100 to 200 milligrams per deciliter. The decreased kidney function causes abnormal serum electrolyte levels. Sodium retention is common, but dilution of the plasma from excess fluid can result in a falsely normal serum sodium level. 135 to 145 is normal, or a low sodium level less than 135. When oliguria develops, potassium is not excreted, and hyperkalemia occurs when levels exceed 5.4 milliliters per liter. Hyperphosphatemia develops with serum levels greater than 4.7 milligrams per deciliter. Serum calcium levels are usually at the lower end of the normal range or are slightly below normal. Acidosis develops from hydrogen ion retention and loss of bicarbonate. However, there may be a decrease in serum carbon dioxide CO2 levels as patients breathe more rapidly to compensate for the acidosis. If respiratory compensation is present, the pH of arterial blood is between 735 and 745. A pH of less than 7.35 means that the patient's respiratory system is not completely compensating for the acidosis. The kidneys are abnormally small on X-ray and on IV urography, and when measured by sonography or CT. A renal biopsy is important in the early stages of glomerulonephritis when protein or blood is first present in the urine. Tissue changes include a variety of cells infiltrating the glomerular tissue, deposits of immune complexes, and blood vessel sclerosis. In advanced disease, when the kidneys are small, renal biopsy usually is not performed. Interventions. Interventions focus on slowing the progression of the disease and preventing complications. Treatment consists of diet changes, fluid intake sufficient to prevent reduced blood flow volume to the kidneys, and drug therapy to control the problems from the uremia. Eventually, the patient requires dialysis or transplantation to prevent death from uremia. Care for the patient with ESKD requiring dialysis or transplantation is discussed in Chapter 71. Nephrotic syndrome, pathophysiology. Nephrotic syndrome, NS, is a condition of increased glomerular permeability that allows larger molecules to pass through the membrane into the urine and then be excreted. This process causes massive loss of protein into the urine, edema formation, and decreased plasma albumin levels. Many agents and disorders are possible causes of NS. Okay, the most common cause of glomerular membrane changes is an immune or inflammatory process. Defects in glomerular filtration can also occur as a result of genetic defects of the glomerular filtering system, such as Fabry disease. Altered liver activity may occur with nephrotic syndrome, resulting in increased lipid production and hyperlipidemia. Patient-centered collaborative care. The main feature of NS is severe proteinuria, more than 3.5 grams of protein in 24 hours. Patients also have low sodium albumin levels, serum albumin less than 3 grams per deciliter, high serum lipid levels, fats in the urine, edema, and hypertension, chart 76. Renal vein thrombosis often occurs at the same time as NS, either as a cause of a problem or as an effect. NS may progress to ESKD, but this can be prevented with treatment. Treatment varies depending on what process is causing the disorder, identified by renal biopsy. Immunologic processes may improve with suppressive therapy using steroids and cytotoxic or immunosuppressive agents. Angiotensin converting enzyme or ACE inhibitors can decrease protein loss in the urine, and cholesterol-lowering drugs can improve blood lipid levels. Heparin may reduce urine protein and reduce renal insufficiency. Diet changes are often prescribed. If the glomerular filtration rate, or GFR, is normal, dietary intake of proteins is needed. If the GFR is decreased, dietary protein intake must be decreased. Mild diuretics and sodium restriction may be needed to control edema and hypertension. Assess the patient's status because vascular dehydration is common. If the plasma volume is depleted, renal problems worsen. Acute kidney failure may be avoided if good renal blood flow is. And that's it.